My name is Dylan Crail, and I'm a student PTA at CBD College. My first patient is a 42-year-old who presents with a right glenohumeral slap lesion, which is a superior labral tear from anterior to posterior. She is in the acute phase of recovery, max protection, and we could come to this conclusion due to the fact that she is just 5 days status post from her surgery. And this type of recovery usually takes about 3 to 4 weeks after rotator cuff surgery. Also, she is still experiencing slight pain at rest, 2 out of 10, and extreme pain at rest would be a contraindication to passive range of motion. So it seems like she was just cleared for passive range of motion, which could only mean she could only be in acute phase of recovery. The treatment goals for this stage of rehab would be pain management. First of all, we can do this through ice packs, non-steroid, anti-inflammatory drugs, as well as pulsed ultrasound. Other things we must do is maintain range of motion, as well as scapular mobilization and stabilization. Now, every case is case by case, and in this case, we must respect the MD's orders as far as limitations in passive range of motion, active range of motion. In this case, for passive range of motion, we can't place the arm into extension, or the glenohumeral joint into extension. We can't place the arm into 90 degrees, past 90 degrees of flexion. We cannot place the glenohumeral joint past 90 degrees of abduction either. Nor can we do 45 degrees of internal or external rotation. We must stay within those limits. As far as active range of motion, we cannot allow any glenohumeral active range of motion. And we cannot also allow any elbow flexion. This would imply contraction of the bicep, which we are trying to avoid during this stage of recovery, as contraction of the bicep can re-aggravate this type of injury. Another thing to keep in mind is that the doctor did not explicitly forbid active assistive range of motion or isometrics, so we can do that as long as we stay within the parameters of what they did restrict. I have conducted 3 exercises which could help the patient through this phase of recovery. For the first one, I would place the patient in the supine, and I would passively place their glenohumeral joint within the scapular plane, and then put it into glenohumeral flexion until they feel pain. I would then lower it, and then I would place their arm into abduction until they feel pain, and then I would lower it. And I would repeat this 5 times until the patient is experiencing less pain, and then we can up the sets to progress from anywhere from 5 to 10. And in this case, we don't want to go past 90 degrees either way. So even as the patient is gaining that range of motion until we take off that restriction, or rather the MD does, we must respect those orders. And for my second exercise, I would then place them side lying on their upper extremity of the left side. I would then take their right upper extremity and place it passively on my shoulder. And then I would take the superior aspect of the scapula and the inferior border of the scapula, and then I would provide force upward for 3 seconds as they resist, and downward force for 3 seconds as they resist. And then I would keep their arm on my shoulder, but then put my hand on their coracoid process, their right side, as well as their medial border of the scapula. And then I would shift into protraction, 3 seconds, at least the force, so they can provide an isometric contraction, and then back into retraction for 3 seconds. This way we can work out those rhomboids as well as the serratus anterior, which are both of those are usually inhibited during this type of injury and post-surgery. And we're also trying to maintain range of motion through the last workout. And for my final exercise, I would put them back into supine, and I would place a towel under their tricep, the right tricep. And this would kind of put their arm into passive flexion, which we want a little bit of cushion to avoid any kind of real extension. I would passively place their elbow into flexion and stabilize their forearm, and ask the patient to force down into the towel. This would provide an isometric contraction, and this would work out their tricep, which is very essential for this stage of recovery. We just must stay within the parameters of the MD's orders. We'll know the patient is ready for the next phase of recovery, which would be the proliferative phase, MOD protection. Usually within the 4 to 5 week range is when they are ready for the next phase of recovery. We must also be sure that they have less pain and more range of motion from the initial stages of recovery, as well as more stability within their arm, more able to just kind of control their movements and just have that sense of stability.